talk about chronic obstructive pulmonary disease, COPD. And of course, it's a pulmonary thing, and it's an obstructive pulmonary process, and it's a chronic problem, so it's something that's gone on for a long time. The best way that I've found to talk about it is to talk about chronic bronchitis and emphysema. Those are the two major parts of COPD, or two of the major causes of COPD is what I should say. They used to be actually included in the definition of COPD, where they don't do that now because there's an endless amount of things that could cause this. COPD is actually kind of a catch-all phrase that will tell you, it's just telling you that there's a chronic obstructive pulmonary problem, and could be caused by whatever. Okay, before we talk about the disease process, I think it's important that we review how the lungs work. So first of all, we got to talk about inhalation and exhalation, right? These are the real basics here. Here's a set of lungs in the thoracic cavity. I don't know if you can see that there. This here is supposed to be the outside of the body, right? Shoulders, lungs are situated inside it. And you have intercostal muscles right in here, right? And your diaphragm right down here below the lungs. In order to get air in, we have to take a breath, right? Our muscles have to work to get the air in, right? It pulls down on the diaphragm. The diaphragm contracts and it pulls down. So instead of being up there, instead of being up like that, the diaphragm will contract and it will come down around like this, right? So it pulls down. And when it pulls down, it's going to pull air down. Also, the intercostal muscles will expand the chest outward. So all that pulls the air down. So you got the diaphragm pulling down, you got the intercostal muscles expanding the chest outward, so air is going to go rushing down in here. Now if you take a look here, the way I drew the lungs, I drew all these little blue lines in here. Don't usually bother with that when I'm explaining lungs and how lungs go about functioning. But in this case, I want to bring them up because it's going to come up later. These here are little tethers. I like to think of them as elastic fibers that attach to the sides of the airways. And so now when this expands out and this comes down, it's actually pulling on those. Right? It gets pulled out and it pulls on those to open up these airway. So not only is it causing a negative pressure for the air to come in, it's actually pulling all the airways open so that air can get pulled in there better, right? It's like there's a little tether attached to every one of your airways and it just pulls that open. Look down here at the individual alveoli. I have the alveoli drawn in here. Of course, they would be all over in the lungs. But so if you're looking at the individual alveoli, when they inhale, and those when they inhale, and the thoracic cavity gets pulled outward and the diaphragm downward, right? Pulls in these tethers and pulls this airway, this bronchial here, out, right? So opens it up. Then when they exhale and it closes in, the tension on these tethers is released, and this here guy kind of comes back in. Okay, so now as we come back over here to the lungs, okay, so there was a good explanation there on how it pulls open. These airways, they don't really have any integrity of their own. There's no bone in it, no cartilage, no anything to really hold them open on their own. So it's these little elastic fibers, and they call them tethers because it's like tethers, right? And they're pulling out on these airways and keeping them open. Now let's talk a little bit about how the airways keep from getting infected, because this also has a lot to do with COPD and the disease process. You know that the air is going to get pulled down in here. The airways have opened up, right? Now I've just see a little box around that little area, and I'm pretending like I'm taking that little area and we're looking at it over here. So as you look here, we've got the airway, right? The airway that was back here. So I drew it again over here on the side, and we've got a blood vessel right next to there. Of course, there has to be blood, right? You have to get the capillary beds up next to here in order to pick up the oxygen. And what happens here, now see these little green cells that I drew in here? Dispersed throughout the endothelial cells of the pulmonary, I think these are stratified columnar cells, but it doesn't really matter. The endothelial cells here on the inside that line the inside of the bronchi, dispersed throughout them is some of the specialized cells. And these guys make mucus. And so they constantly are producing mucus. Book that I got, we make about a liter of mucus a day. That's a hell of a lot of mucus. All right, so I just drew that green line there to demonstrate or to represent the amount of mucus that is lining. It's a constant flow of mucus going through the lining of our airways. And then out of all of these cells here, you have cilia. Everybody knows that, right? Everybody knows that we have cilia. It's something that you learn in kindergarten, I think. Well, grade school anyway. So all that little cilia that I just drew in there, those are the little hairs that constantly wave forward, right? These guys here are just waving that mucus up, right? The mucus can't just go in there and sit. Whenever we breathe in air, we breathe in lots of pathogens, right? We do not breathe in sterile air. There's lots of junk in the air that we breathe in. So we got some pathogens in here. Right, I kind of dotted that with pathogens. They're going to get stuck in this mucus. Mucus is sticky. They're going to get stuck in that mucus as this expands, and then it contracts down on them. It just gets them all stuck in this mucus, and the mucus is constantly, it's like an escalator, it's just constantly moving up forward, all the way up and out the throat, and we end up swallowing it, right? As it gets up there, we kind of, every once in a while, we'll clear our throat, we swallow. That's why we're constantly swallowing. We're always making saliva, and it washes it down. This stuff just goes up there and gets washed down. So whatever nasty pathogens we breathed in, get caught in that mucus, go up there, swallows down, gets into the acid in the stomach, and boom, it's history. We just killed it, right? That's how it's supposed to work. Now let's look sometimes at some things that can go wrong. Lots of things can cause this problem. I'm going to go ahead and I'm going to pick on smoking. Smoking is the easiest example to use. Seems to be the example everybody likes to use. It's the one I'm going to use. So as you smoke, you are bringing a constant irritant down into these airways, right? Toxins and irritants. And they get stuck in the mucus here. And you're bringing them in constantly. The irritation down here makes the Golgi bodies say, hey, something's coming down that we don't like. I'm going to make more mucus. Make sure that we get it stuck in my sticky mucus. So it makes a lot more mucus, right? And it can be any irritant, but I'm going to say cigarette toxins. So it's making a lot more mucus in here. And unfortunately, another thing that happens from this constant irritation is these cilia end up being destroyed. So you're making more mucus. You could actually use more cilia, right? But you got less cilia. More mucus, less cilia equals lots of mucus plugs down in your airways. We're going to take a look here at the individual alveoli again. So from this irritation that's going on now, you got a lot more mucus. Instead of just a nice thin line, we've got big globs of mucus here. So, remember, this is on inhalation when everything's pulled apart. Then when the person goes to exhale, everything goes back together, right? The airways get smaller, the alveoli. And now, but look at this mucus over here. And imagine what it's going to do over here. Draw the same amount of mucus, or I'm trying to. It ends up closing off that whole airway, right? right? So in this case here, the person's exhalation is what's being compromised than you are in your inhalation. So this guy's going to fill up, and you keep doing that over and over. This guy fills up, you pull more air in there, you're forcing more air in here, and you're not getting rid of it. So then on exhalation, you've got this little thin guy here, but this guy here starts getting blown up. Right? Your alveoli actually get stretched out because they keep bringing in more air. Your whole lung fields end up getting stretched out. This is why one of the symptoms of COPD is being barrel-chested. Okay, now another problem that's going to happen here in these airways is they start getting all this extra mucus globs in here, right? And you're not moving that mucus up and out, so the pathogens get stuck in there and they grow and they start reproducing. They got this great place, all of this wonderful mucus to grow in, right? So they get in there and they stay there because you don't have the amount of cilia and stuff. You got all this mucus just kind of sitting there, and the person coughs every once in a while, but it's not near as effective as the normal system when it's working right. Right, so you got thick mucus and it's sitting there and you get pathogens growing in it. So that's when you start getting colored, right? It starts turning green and brown and all yellow and all these colors that show that there's a pathogen in what's you're coughing up. So as that happens, right? So now you get pathogens in here, right? And so this is all. And so now you got. I'm showing that you have the bloodstream here. You got dendrite cells there. Dendritic cells, that's what that's supposed to be. You got it right underneath the layer of the bronchi, and it actually reaches up and grabs a hold of those pathogens that are growing in there, and it takes it. It gets picked up in the bloodstream then, and well, okay, so it reaches up there and it starts an inflammatory process, right? Ends up going to the lymphatics, and there it's decided which white blood cells are going to kill this specific pathogen, and boom, they're all getting called here by all the cytokines being released here from this inflammatory process. So that all gets called in there. You get a whole bunch of white blood cells going in there to join in on the fight. So then inside these white blood cells, you know what's in them? Lots of proteases, lots of enzymes. Proteases, and the ones we need to talk about right now are their proteases and elastases. What are they going to do? Well, what they're for, they're inside the white blood cell. They will release these enzymes into the area so that they can destroy some of the pathogens. And also, when a white blood cell engulfs a bad guy, right, engulfs that pathogen, right, phagocytizes it, can't just let it stay in there. It has to break it up. So it has these enzymes in there that will break that up. And those things are made out of protein, right? These bacteria or whatever you would happen to inhale are made out of protein. So it pulls it in there and it uses proteases, protease, right? Ace is always an enzyme. Ace means it's breaking something up. What's it breaking up? Look at the front of the word. Protease, breaking up proteins, right? Elastase, breaking up elastin. Elastin is a specific type of protein that gives it elastic quality, and that's these little blue guys here. They are made of elastin. So the fact that they're made of elastin, and now you have a lot of elastin being let go, because you got to remember, these white blood cells come in there, and a lot of them die. Whenever you have a battle, you don't see just one side of that battle dead, right? You look at the old pictures of Civil War, you don't just see a whole bunch of blue uniforms. You see blue ones and gray ones, right? Both sides are littering the field. So that's what's happening here. Lots of our immune cells are dying there in the fight, and they are releasing all of these enzymes into the area. So you got that increased enzymatic action going on, and it just starts destroying. And if this is happening chronically, over and over and over, you are killing off more of these elastic tethers here, right? So now that can happen from any kind of inflammation, and that's where we start talking about emphysema. With emphysema, you have chronic inflammation from something. Can be from smoking, very often is, and even if you don't have a pathogen in there, or even the increased mucus production, you will still get the irritation from an irritant. So even if you don't have the pathogen or the increased mucus production, you still can have an irritant down there causing the inflammatory process and causing lots of extra enzymes in there and causing the destruction of elastin. And when you get the destruction of elastin, the lung loses a lot of its compliance. So you've lost the elasticity in the lungs. So now the lungs aren't, when you go to exhale, you're not pushing that air out anymore, right? Because you've lost that elasticity in your lungs. So the fact that your lungs can't expand and contract are going to going to make it so that you can pull the air in, but you can't get it out very well, right? So when we're talking about emphysema, we're actually talking about a lot. There's scarring and fibrosis in the lungs themselves. So the total lung tissue has lost its elasticity. So what do you think a person's ABGs are going to look like? Well, you're going to have, your CO2 is going to be high, right? Because you're not able to get rid of it. So you're not exhaling that out. So your CO2, you're going to have an increased CO2. So let's say we have a CO2 of 65. Now this is a chronic process, so your kidneys are going to be compensating, right? And they're going to be holding on to bicarb and making more bicarb. So your bicarb is going to be high to try to offset the acidity from the CO2. So your bicarb ends up, normal is 22 to 26, so let's say it's about 45. We're giving some big numbers here, right? What's your pH going to be? Well, let's just say this person here is fully compensated. So we're going to say it's normal, and we're going to say it's a 7.36. So it's going to be to the acid side of normal. So 7.36. So we know that there's an acidic problem, even though it's normal. It's in the norm between 7.35 and 7.45, but these two numbers are both off. So let's take a look at that on our tic-tac-toe thing. Let's go acid, norm, base. Right? So CO2 is high, so that sucker there is definitely over here. Right? Your bicarb is high, so that's too much base, so it's going to be over here. Don't put the results, you just put the bicarb. So your bicarb. And now your pH is in the normal range, but I like to go 7.4 down the middle. It's to the acid side of 7.4, so you go pH is in the normal range, but to this side of it. So that tells us that we have, since it's in the normal range, it's compensated, and it's fully compensated, or it wouldn't be in the normal range. So we got, and we know it's acidosis because it's to the acid side of 7.4. So it is fully compensated, and what is over here, right? Well, it's a high CO2, so it's an acid, so the thing that matches, that is also on the acid side, is your CO2. So that CO2 is always respiratory, right? Bicarb is always metabolic. So the CO2 is on this side with that, so it's fully compensated respiratory acidosis. That's a very common ABG result for somebody with chronic obstructive pulmonary disease. So how are we going to treat this person? Well, there's not really a way to reverse the process, but you can definitely slow it down. It's an inflammatory process, so steroids is one of the things that you'll use. It's a great symptomatic treatment, helps them with their symptoms. And it can also slow down the process because the process is caused by inflammation, right? Destroying lung tissue. And definitely, if you can stop whatever is causing it, like smoking, you got to stop that, right? You're breathing something in constantly, you can't do it anymore. And so when somebody has an acute exacerbation of COPD, it's got to be handled pretty quickly. So what you'll do then is you'll give them some of the beta-2 agonists, right? Albuterol, give them albuterol treatment so that they can, so it will open up those bronchi and hopefully they'll be able to breathe better. You're probably going to give them some IV steroids. You might even give them something like magnesium sulfate or theophylline, something else to cause bronchodilation over a longer period of time than what the beta agonists do. And so how are we going to diagnose somebody with COPD? For one thing, physical examination. You can look at, see their anterior, posterior chest diameter, see if they're barrel chested, right? That would be one thing that would give you a clue that they might have COPD. Or they got a chronic cough, are they coughing all the time? Because definitely the chronic bronchitis is going to cause you to cough as you try to cough up that mucus, but even the irritation down in your lungs from emphysema without the mucus, then you will have a non-productive chronic cough. Okay, so symptoms would be maybe barrel-chested, wheezing, may have chest tightness, dyspneic, chronic cough, that's kind of a big one there, chronic cough, an increase in their CO2 on an ABG, an increase in their CO2 and a decrease in their PaO2. And down here, decreased oxygen saturation, right? You can expect to be anywhere from 88 to 94%. 94 would be a little bit high on them. 88 would definitely be a little bit on their low side. And in fact, I'd say usually 90 to 92. I've seen a lot of doctor orders that will say titrate O2 to keep their oxygen saturation between 90 and 92. And what's the reason for that? Why don't we just get it up to 100%? Well, the reason for that is because the receptors that we have that give us the stimulus to breathe, they react to the high CO2 level. Actually, they react to the acid level. So when you get a high CO2 level, it makes you breathe. Well, this person always has a high CO2 level, and it's like these receptors just get numb to it. They quit reacting to that. But we have a secondary stimulus to breathe, and that is from a low PaO2 level, right? So when your O2 level gets low, that's what gives you the stimulus to breathe. Without that, your acidity is going to go crazy, right? Because you're not going to be breathing at all, right? So if you put their oxygen level up really high, they'll stop breathing completely, right? And you can make a bad situation worse. I've taken care of people where that has happened. In fact, I remember just one. I remember it real well. And the person looked really, really bad. But I will say this, the oxygen level dropped because they weren't breathing, and then they started breathing again. So, yeah, but anyway, you don't put too much O2 on you. You usually titrate it to keep their level, their O2 level, between, depending on what it is on the person, but you'll try to keep it usually between 90 and 92, sometimes 88 and 92. Just depends on how the order is written, but you would definitely question an order that had you on high oxygen, that had one of these COPD people on a high oxygen. Okay, so other than the clinical data that you collect from evaluation, from assessment, so other than the clinical data that you gathered from your assessment, we also have some lab tests. Like I said, your ABGs are going to show some things, right? Some high CO2, right? Some low O2, you're going to see that stuff. And you also are going to rely on PFTs, pulmonary function tests. The pulmonary function tests, there's two of them that will show that there's obstruction, right? And that's what you're looking for. You're looking to see, okay, they got a breathing problem, you know that, right? You want to see if it is a problem with obstruction. And two PFTs will do that for you. One is forced expiratory volume, right, in the first second. So it's written down as, it'd be written down as FEV1, forced expiratory volume in the first second. So that means when you're pushing out, it's how much air came out in the first second that you were doing that. The other value we're going to look at is the full vital capacity. So that's the entire amount that you can push out, right? Over however many seconds, usually like 3 or 4 seconds, or 4 or 5 seconds, I don't know. So I'm going to use this little table here to show how these values work. So you take a person, you have them blow out into this machine. I don't really know how the machine works, but they blow into it. And so as this person here starts that exhalation, that forced exhalation, as hard as he can go, try to shoot for that there, right? It's gonna, boom, go like this. So that's the curve it's gonna make of the pressure there. So in 1 second here, go straight on up. At the time, this is the amount of time going by. So in the first second of him forcing the air out, he's right here. He's forced out 4 liters. Over on this side we have liters, the volume of air. So 4 liters here has been forced out in the first second. And as you can see, it keeps going up all the way up to 5 liters. Takes 4 seconds there. But so the forced expiratory volume in the first second is 4 liters. The full vital capacity is 5 liters. So if you take 4 divided by 5, if you get out your calculator, divide 4 divided by 5, you will end up with a 0.8. So that means 80% of what this person, of this person's full amount of volume that he blew out, which is here, the 5, right? The full amount that he could blow out is up here. So he could blow out 5 liters, but he blew out 4 of it in the first second. So that means that 80% of what he can blow out, he blew out in the first second. So now if you think about it, that means he doesn't have an obstruction, right? Because he was able to blow most of it out right away, right? Otherwise, if those airways were closing down on him and he couldn't get out, couldn't get the air out, it'd take a lot longer than that. Let's look at that on here. A person with COPD blows in there. He pushes really, really hard. He's going out like this, right? And it comes like this. Well, you can't get it quite as much out, but if you look in the first second, he only had 1 out, right? So let's switch colors here. I'll switch over to blue. So his forced expiratory volume is in 1 second is 1, and his full vital capacity, the full amount, the most he could get out, was 4. Well, 1/4. That's easy. You know it's 0.25, right? 1/4 is 25%. So it's 0.25 is your result there. And what you want is if the person has an obstruction, it would be below 0.7. So he definitely has an obstruction. This person here does. This person up here does not, right? Because he was able to get most of that air out. So 0.7, 80%. 0.7, 70% is above 70 is normal, below 70 is not normal. So below 70 will show an obstruction. That's a diagnostic criteria. Below 70, below 0.7, which is 70%, but below 0.7 on your forced air. Oh, wait a minute, I should have wrote that down here. This is your full vital capacity, right? So your forced expiratory volume divided by your full vital capacity should be greater than 0.7. If it's less than 0.7, that's diagnostic criteria for an obstruction. So you know that you got an obstructive pulmonary problem now. And if it's going on for a long period of time, it's chronic. So you have chronic obstructive pulmonary disease. So these guys here, so that there, like I said, is diagnostic in its own self. So now you know that you have a pulmonary, an obstructive pulmonary disease. Now let's take a look. We can also use these tests to rate it, to stage the severity of the disease. So you've already got the fact that you have an obstructive disease because you came out with 0.25. Now we got 1 liter here, right? So what's normal? What's normal for your forced expiratory volume in 1 second? It's not really a normal. It has to be individualized. Why does it have to be individualized? Well, everybody's lung volume is different, right? My lung volume is a lot bigger than a little girl that maybe is 5 foot tall and she has smaller lungs, right? You can't expect the same amount of volume to come out of her as you would out of me, or out of a little kid or something, right? Or a great big tall basketball player would probably have more volume, right? He's going to have more volume than I got. So you have to individualize it. There's 4 criteria that they use for individualizing lung volume. Once they get the individual value, they call that the predicted value, right? The predicted value for that individual. So normal for that individual would be 80 to 120% of that predicted value. Where they get the predicted value is they use some criteria. They use the patient's height, their gender, right? So how tall are you? Are you male or female? Your race. Every race has a different, I don't know how they calculate it, but every race's lung volume is a little different as compared to their height. And one example of that would be like a white person that's 6 foot tall is usually taller from the head to the waist than he is from the waist down, right? And when you compare him to an African American. So an African American at the same height has a smaller lung than a Caucasian would. So that's why they put race in there, and I have no idea what like a Hispanic or Asian, but anyway, somebody else has to figure that out. I don't really care. You put it on a little table and it spits out the number for you. So you're going by height, age, race, and gender, right? Those 4 things: height, age, race, gender. Those 4 things will give you a predicted value. And so then they take that predicted value, and normal will be at least 80%. At least 80% is normal. Now we've already figured out that we have an obstruction because we did our percentage here of forced expiratory volume in 1 second, percentage of your full vital capacity, right? So that's how you figure out that they have an obstruction. Now you want to stage the obstruction. Get rid of this stuff down here. Okay, so now we've established that we have an obstruction because of your FEV divided by your full vital capacity was less than 0.7, right? So less than 0.7, we have an obstructive process. Now we want to stage how severe is this obstruction process, and we do that just by the FEV, and we compare it to the predicted value that we've already figured out. Right? So 80 to 100% is normal, right? So if the person has symptoms and they've already been shown to have an obstruction, with the FEV divided by the FVC, the FEV divided by the FVC, it's screwed up here. So you've already shown, because that was less than 0.7, so we know that they have an obstruction. So now we're going to stage the severity of the obstruction. If you have 80 to 100% of your predicted value, they're going to say it's mild, right? Because that's normal. 80 to 100% of your predicted value is considered normal. So if you're in that range, they'll say, okay, we know you have an obstruction because of the ratio that we figured out, or because of the percentage, right? We know that we've already decided that you have an obstruction by dividing those two numbers, but now we look at this, well, it's not much of an obstruction because your FEV value is actually normal. So you have an obstruction, but it's a mild problem, right? So now stage 2, if you're 50 to 80% of your predicted value, then that means that they are in stage 2. Stage 2 is a moderate, right? And what's moderate? Medium, I guess. So stage 2, 50 to 80% of the predicted value, we know they have an obstruction, and it's a moderate obstruction. So your COPD is of a moderate, staged as moderate, staged as stage 2. So now, if you're 30 to 50% of your predicted value, you are in stage 3, you are severe, right? And if you are less than 30% of your predicted value, you're at stage 4 and you're very severe, right? These are the people who are gasping for air with oxygen in their nose 24/7, can't do anything but just sit there. All right, now I'm going to talk about a significant complication that you can get with COPD, usually in the end stages of COPD, and that is cor pulmonale. In fact, one of the students, I don't remember who, but said that in the lab, Sarah explained it really well to you about superior vena cava syndrome when we were talking about superior vena cava syndrome, when we were talking about cancer. And I said, oh, okay, but I was a little bit confused because I was trying to think how she worked that into the lecture. And then when I was doing this, I thought, she wasn't telling them about superior vena cava syndrome. She was telling them about cor pulmonale. There's a difference. Well, it's a pretty significant difference as far as the pathology goes, or pathophysiology goes, but there's a difference in the symptoms, and I can see how the student got this a little bit mixed up, but there's a difference in the symptoms. On the test that has this on, it'll be your exam 3. If on the back, and I'm not going to ask you to do this, but if you're watching this video, you're going to know to do it. On the back, write down the difference in the symptoms of cor pulmonale and superior vena cava syndrome. Write down what's different about the symptoms in those two things. Real easy. I'm actually just going to be looking for one thing. If you don't get that one thing on there, there might be a whole list of things you can come up with. If you don't get the most important thing on there, I won't give you that point. But otherwise, I'll give you an extra point for that. So you go ahead and get that right? You go ahead and get that on there, look that up, and you can write that on the back there, and I will give you that point. Difference between cor pulmonale and superior vena cava syndrome. This is probably what Sarah taught you. I don't know if everybody in this room has had that. I think you probably have, but I'm going to tell you again anyway. Do it every year, kind of like talking about this. Now, as you can see up here, I've got the heart the way a little bit more anatomical, right? You got the heart, and the aorta comes out, goes to the body, and you got the pulmonary artery coming out and going off to the two lungs, right? That doesn't really serve my purpose when I want to talk about cor pulmonale. This diagram over here does. What I've done is I've drawn the heart, I've taken the heart, right? You got a heart, it's like a Valentine's Day heart, and I split it apart. Put the right side over here, left side over there, right? So let's go ahead and do that. Left heart, right heart, right? So now, what happens in COPD, right? We've talked about, you get some fibrosis, you get some problems there, and then you get your pulmonary capillaries actually, a lot of them end up contracting because they're saying, hey, I'm not getting much ventilation in here, let's shunt this blood somewhere else where we are getting ventilation, and that ends up happening all over in the lungs, so you end up with an increase in pulmonary pressure, and when you get that increase in pressure here in the lungs, the right heart has to push into an increase in pressure, right? So when it tries to push into the increase in pressure, it starts failing. Left heart's not running into that pressure, it's going out to the body. It's pushing it out to the body, and so the blood is coming in here, boom, but it can't keep up, it can't push it that way. So you get the pressure ends up translating out to the right heart and out to the body, right? So what do you end up with? You end up with bilateral pedal edema, a dependent pedal edema, or dependent edema, right? So whatever is low, usually you're going to end up with some edema there, right? It's a right-sided heart failure caused by the increase in or the decrease in elasticity in the lungs and the increased pressure in the lungs. And you say, okay, the right side, why does it end up in the body? The best way, and we're going to be talking about heart failure here, and that's the main reason I want to talk about corpuscle, because when we talk about heart failure, this little tidbit of knowledge is going to really be helpful. So right, let's say you got a highway, boom, right back when I used to go, and here's an on-ramp, right? You got your cars coming like this. Right, there's your cars. Boom, he gets in a crash. Alright, so now you got a crash there. So the traffic's coming along here. Where are you going to have a buildup of traffic? Down here past the crash? No, it's going to be behind the crash, right? So you got one coming here in the off-ramp, right? Boom, you end up with all these cars piled up behind the crash. Well, that's what's happening here. This is where you have the problem, and that translates to all the traffic behind here piles up, right? And it can't get into the lungs, right? So it all piles up behind that, and that is from the body, right? Because it can't get from the body back up into the heart and into the lungs. So it's behind that, right? Because this here is the direction. Just draw it like this, right? That's the direction of your flow. Right? So if that's the direction of your flow, and you got the car accident here, it's behind here where you get the buildup. So you got all this edema and everything back behind there. So what are your symptoms going to be? You're going to have bilateral pedal edema, actually dependent edema, engorgement in the liver, right? Because it'll be backed up into the liver. Both the superior and inferior vena cava cannot empty into the right side of the heart. So everything backs up behind that. Right, so, and mostly where you're going to see this edema is going to be like down in your feet and like I said, in your liver, jugular venous distension, right? You'll see all these things. All these things that are signs of heart failure, right-sided heart failure, you're going to see with cor pulmonale.